Alright, so in this video we're going to talk about congestive heart failure, which is a complex pathophysiologic process that's characterized by pulmonary congestion. And this is typically caused by either the heart's inability to eject or to fill with blood. So pulmonary congestion, if you are assessing a patient, is going to look like adventitious breath sounds such as crackles, dyspnea or difficulty breathing, and orthopnea, which is just the inability to lay flat due to the feeling of an inability to breathe. So congestive heart failure really has three stages of progressions. First is going to be elevated filling pressures with an unchanged stroke volume. Second, you're going to see a decrease in the stroke volume with a compensatory increase in heart rate. Remember that cardiac output is the combination of stroke volume and heart rate. So as stroke volume decreases, patients are going to compensate by increasing their heart rate to maintain a cardiac output. And the third stage of heart failure is decompensated heart failure, which is where the cardiac output actually begins to decrease as either the heart can't keep up with increasing the heart rate any further, um, or there are further decreases in stroke volume. The causes of heart failure typically are coronary artery disease and or uncontrolled hypertension. Can also be caused by valvular issues or damage following a myocardial infarction. There are other causes, but these are mostly what you're going to see. There are different ways to characterize heart failure. First, we'll talk about left-sided versus right-sided heart failure, and then we'll get more into the systolic versus diastolic heart failure. So first, on left-sided heart failure, this is usually going to be caused by hypertension, CAD, an MI, or aortic valve disease. And that aortic valve disease is going to be because the valve that's between the left ventricle and the aorta is the aortic valve. So if that valvular area is showing some disease, then that can cause left-sided heart failure. Some of the signs and symptoms that you're going to see in left-sided heart failure include dyspnea, orthopnea, pulmonary edema, which is going to result in pink frothy sputum, and pale or clammy skin. And that's just going to be because there's going to be a decrease in the amount of blood that is going from the left ventricle through the aorta and out into the body. So with that, you're going to have decreased delivery of oxygenated blood to both the organs and the skin, so that's going to show up as pale, clammy skin. And then right-sided heart failure typically is going to be caused by pulmonary stenosis, pulmonary hypertension, maybe severe emphysema, and most commonly caused by left-sided heart failure. So typically what you'll see is the most common cause of right-sided heart failure is actually left-sided heart failure. And we can just take a look at this great drawing from this artist that I know right here, and basically explain why that's going to be. So when the left side fails, right here, typically that's going to be in the left ventricle. No longer is blood able to get out to the aorta, so it's going to back up maybe into the left atrium, which is going to back up into the pulmonary artery and then into the lungs. And then that congestion is what's going to lead to eventually higher pressures, which the RV is not typically able to overcome, and then cause right-sided heart failure. So you can see it's really a whole system there, where typically issues further down the line end up causing right-sided heart failure. Some of the signs and symptoms of right-sided heart failure are going to be lower extremity edema and hepatomegaly, and that makes sense. Just like we talked about how the LV is going to back up into the lungs, the RV, that gets its blood supply from the right atrium, which then gets its blood supply from the inferior and superior vena cava, right? So that blood's going to go even back through those systems, and then that's what's going to cause edema prior to the right ventricle and the right atrium, and that's going to present as lower extremity edema usually. We can then talk about systolic heart failure, which is heart failure with a reduced ejection fraction, typically is how it's referred to now. So ejection fraction, remember, is the percent of blood that is pumped out with each contraction. So normally that's going to be anywhere from 55 to 70%. With some mild dysfunction, you're going to see that 45 to 54. moderate dysfunction 30 to 44%, and severe dysfunction less than 30%. So that means if you have 100 mLs of blood um, enter into the left ventricle and you have severe dysfunction, then less than 30 mLs are going to be pumped out with each contraction. So that 70% is going to be staying in that ventricle, circulating around, and can potentially increase your risk for things like blood clots as that blood stays stagnant. And all these are going to usually be measured via some type of echo, whether that's transthoracic, which just means they put a probe on the skin, or they can also do transesophageal, which means that they would go down similar to an EGD, which is where they will look into the stomach through the mouth. But instead, this probe is going to help them measure cardiac function. Systolic heart failure is typically caused by coronary artery disease, dilated cardiomyopathy, chronic volume overload, or even later stages of chronic pressure overload. Think aortic stenosis or chronic hypertension. As we talked about, when you have that backing up into the left ventricle, that's going to cause an increase in volume there, and that's going to cause what's known as eccentric hypertrophy, which just means thinner muscle and dilated ventricles. So with systolic heart failure, you're typically going to see dilated ventricles and like a weak, thin muscle. Versus diastolic heart failure, which we'll talk about now, which is heart failure with a preserved ejection fraction, which just means that the ejection fraction is adequate, but there's an inadequacy in the filling. So even though you're able to pump out an adequate 55 to 70%, you're not filling up with, like that example we talked about earlier, you're not going to be able to fill up with that 100 mLs. You might only be getting 50 mLs of blood into the ventricle. Obviously, these are just examples for easy numbers, but without the adequate filling, you're still able to eject the correct percentage, but there's just less blood that actually gets into the ventricles. This is usually caused by something like tricuspid or mitral stenosis, which means that the valve between the atrium and the ventricles are stenotic, or have some type of reason that it's just like a tight space, and therefore blood's not able to get through from the atrium to the ventricle, or an obstructive cardiomyopathy. And in this example, ventricular walls are going to thicken. So you're going to have smaller volume chambers and thick muscles there, and that's going to be because they're going to be pushing against these high pressures, like we said in the smaller area valvular space. They're going to need higher pressure in order to overcome this, and this thick muscle is going to be prone to ischemic changes and damage. So it's going to be really important to make sure that your oxygen supply demand is adequate for the ventricles. So as your heart rate increases, that's going to increase the amount of demand that you may have from those muscles, and at the same time, cardiac muscles perfuse during diastole. So if you have a higher heart rate, there's less time for those ventricles to actually perfuse themselves. So the thick muscles are really at risk for ischemia. The treatments for heart failure are going to be based on 4 goals. We'll look at those right here. And the 4 goals are to reduce oxygen demand, improve pumping action, relieve pulmonary congestion, and to minimize sodium and water retention. Some of the common meds that you're going to see for this include ACE inhibitors and angiotensin blockers, which are going to work by decreasing the workload via vasodilation and at the same time decreasing fluid retention. Beta blockers may also be used, and that's going to be to decrease the heart rate, which, as we just talked about, is going to decrease the oxygen demand and at the same time improve your supply to the ventricular muscles. Diuretics may also be used to decrease fluid retention and at the same time help reduce pulmonary congestion. You may see digoxin from the digitalis class, which is going to decrease heart rate, which we said will decrease your oxygen demand and improve your oxygen supply, and at the same time digoxin is going to improve your pumping action. And lastly, you may see venous vasodilators, which are going to allow the vessels to hold an increased amount of blood and also just make it easier for the pumping action as well. So those are some of the common treatments and some things to look out for with systolic, diastolic heart failure, as well as left versus right heart failure. If you have any questions, feel free to leave them in the comments below.